comes in from the interaction. The interaction with this couple. The other tests are just subsidiary.
Okay.
Yes.
There's a time someone mentioned that if you have a child above the age of, okay, doctors normally say 35, okay, 35 or 40 and above or something, even the quality, would I call it the quality of the child? Okay, the quality of the product you're having will either not be good or have some issues or something. Is that a myth or is it true?
It is true, because the fact is advancing maternal age comes with reduced quality of the egg. Reduced quality of the egg means the DNA of the egg may be tampered with. And the more the DNA is tampered with, there is what we call chromosomal abnormalities. You're at a higher chance of producing a baby with chromosomal abnormalities. The common ones is what we call the Down syndrome.
The Down syndrome, yes. Now, how do you classify or how do you consider quality of an egg when you're rating? Because you know there's always that talk where they say the quality of the egg or the quality of the sperm, and what are those things you look at, and if they're hazardous, is it natural or is it connected to anything chemical or something like that?
Obviously, exposure to chemicals puts you at risk, but most of it is natural. Age comes in first. But we can actually assess the quality of this egg through blood tests. There are blood tests we do, and there are hormones. One is called the AMH, anti-Mullerian hormone. So you look at the value and it will give you an idea that the quality of these eggs could be low. There are other hormones that you can run. So before this couple conceives, you actually counsel them and say, we could conceive, but there is a possibility of a chromosomal
disorder.
And good enough these days, we have options. We can diagnose those chromosomal abnormalities
before conception.
Before the baby is born. If we are doing IVF, we are going to do what we call PGD,
which is
pre-implantation diagnosis. So we're able to screen this baby before we implant the baby new if the baby has an abnormality. Or let's say you conceived naturally, even at about 12, 13 weeks, through a simple scan and some blood tests, we are able to tell that this baby actually has an abnormality. And then usually most of the time the couple is cancelled, whether to go ahead with a pregnancy or think otherwise.
So besides age, what are those other factors, besides age, what are those other factors that could naturally lead to infertility?
Well, looking at, I've not talked of the men yet. Looking at the woman, really to classify it simply, you just have to look at her anatomy, what we call the anatomy. Look at her eggs, look at her tubes, look at her uterus, look at her cervix.
When all those are fine.
When all those are fine and you've evaluated and everything is okay, but she still can't conceive, then you look on the other side. Yes, because I've told you, the men take the same percentage. It is 35-35%.
So for these men, okay, because you know it's really hard to convince men to go and check out their fertility and all that, and that the blame is normally apportioned on the women most of the times, What would be the reason, or what would be a cause? Let's say if there's a medical condition someone has, say hypertension or something. I was reading recently on Google, though we try to keep away from Google, but I was reading on Google, there's some medication that is prescribed that actually leads to infertility. So how would you deal with a patient knowing maybe, okay, this patient is maybe, let's say, diabetic or hypertensive, and this is the medication they are doing, and they've done it in the long run, Looking at all these other factors and you've put them aside, this medication could be the cause of their infertility. Is there a way you can reverse that effect?
Because you have to look at the comorbid, what we call the comorbid factors. This person is diabetic, this person is hypertensive, has high blood pressure. All all those, especially diabetes, because most of the time diabetes comes with a little bit of sexual dysfunction, erectile dysfunction in men, and also a little bit of decreased sperm counts. So this person needs his diabetic medicine, and then they also need to conceive. The main focus would be control the diabetes, because as long as the diabetes is well controlled, most of these complications don't really happen quick. And the other thing is, like we shall look at the men's evaluation. Our evaluation is much more simpler compared to the women.
Oh.
Yes, because the women will have to do quite a number of tests. But for the men, most of the time, just a simple semen analysis, just one test will give you an idea of what is going on. Yes.
Okay. We are going into a short break, and when we return, we are going to be looking at the treatment options we have for infertility, especially in Uganda, because there is no need for us giving you an option that is going to work for only the people in West Africa, and we don't have here in Uganda. When we return from the break. You're welcome back from that short break, and before we went into the break, we were looking at different things that cause or lead to infertility, and we talked about we're going to be looking at available treatment options we have in Uganda. But before we go there, we still want to further look at the evaluation a woman undergoes to rule out or to confirm they are infertile besides the natural ones. Doctor,
yes.
Before we go into the treatment, the evaluation process.
Yes, the evaluation process. So as I was saying, a woman's menstrual history is very important.
Okay.
If she's having her period, if she's missing the period, and how regular her period is, that is very important. So after looking at all the history,
Okay.
we normally do some tests. One of the tests which we are seeing there is assessment of the tubes.
Okay.
That is laparoscopy. So a tube is, a dye is injected through your cervix, and this dye should be able to move through the uterus, reach the tubes,
Okay.
and then power out.
That the dye.
The dye. If you're observant enough, you will see something blue coming out.
Yes.
So that shows you that your tubes are open.
Okay.
That
So
is, yes, that is a tubal test.
Oh.
Yes.
Okay.
So that is more advanced. But we have the simpler options,
Okay.
which is common. It's called the hysterosalpingogram, the HSG. It's like an X-ray.
Okay.
So this hysterosalpingogram is done specifically on specific days of the cycle. If you do it on wrong days,
It will give you wrong
it will
results.
give you wrong results, which the laparoscopy doesn't. That's why it is more advanced.
For it, it's accurate.
It's accurate.
Okay.
Because you're seeing the tubes. Yes. So the hysterosalpingogram, we normally do it on the 10th day of the cycle.
Now, when you talk about the 10th day of the cycle,
Yes.
many women,
Yes.
a big percentage, even up to about I think 85 or 90%, don't really understand their cycle. They don't know what day 1 is. They don't know what day 15 is. Like they just start counting days when they are on their period, and they say this is day 1. But many women do not know.
Okay. So the moment you begin spotting, that is day 1.
The moment you begin spotting,
you don't have to wait for the real flow. The moment you begin spotting, it means your endometrium has already started shedding. So that is day 1. You count that as day 1. 2, 3, 4, up to 10. That's when we do the HSG.
okay?
Yes. And then, as we can see, that is a little bit of ovulation and infertility.
That is okay. From the 12 to the 24 hours.
Yes. Because the egg starts maturing from the ovaries. It has to be, after it has matured, it bursts.
Okay.
So the tubes have to pick it up, transport it through the tube. At around stage 5 there, that's where it meets the sperm. After meeting the sperm, now it becomes a baby.
Okay.
But that baby can't grow from there.
It has to move
If it
down.
stays there, it becomes an ectopic. So it has to move from there and go to the womb.
So what happens after number 5 or number 5? If there are other days,
Yes,
like
those are other days.
if someone has not had intercourse in those days, that the egg ceases to be valid, or?
Yes, the egg may cease to be valid.
Oh,
Yes.
okay.
So we can actually test if a woman is ovulating or not. Just from even a simple home test.
Okay.
We have what we call ovulation kits. They are like urine pregnancy tests. So your doctor will advise you on this day and this day, check your urine.
Okay.
If it turns out positive, it means within 24 to 36 hours, you're going to be ovulating. Or monitor your cervical mucus, what is coming from down. If this mucus is slippery and you can stretch it, that is a sign of ovulation. Or monitor your body temperature. If you've been monitoring your body temperature and all of a sudden it increases by 1 degree or 2.
But it's hard to tell, eh?
It's hard to tell because you have to be observant and use the same spot to monitor your temperature. If it is the mouth, let it be the mouth. If it is the armpit, let it be the armpit.
Okay.
So if there is that sudden increase, also you can tell that you're going to ovulate.
Okay.
Yes. So that is to do with the ovaries, and obviously for the advanced age, we normally want to check your ovarian reserve. How much is left?
You can really tell how many eggs are left?
Yes, we can tell.
Okay.
How much is left? Do you have eggs or you have nothing?
Okay.
Because if you have nothing, it changes the story. It means a third party has to come in
To donate?
and donate an egg.
Okay.
And now that is IVF. Yes. So
Okay.
we check the ovaries. The uterus simple tests, a scan will really tell us, are we having fibroids in this uterus, are we having polyps, are we having anything. And then the scan can also tell us if the uterus is normal or abnormal.
How does a normal uterus look? Just, okay.
Because a normal uterus has one cavity where the baby grows. But we have some abnormalities where you find that within that cavity there is a septum. There, we have a picture of that.
Could it be that?
Yes, you see? That thing coming from down. So it divides your womb into two.
Oh.
So it could be a complete septum giving you two uterus.
Two uterus. Oh, okay.
And we've seen couples conceiving in one uterus.
And the other one does
the
not
line is
conceive.
empty.
What's the percentage of baby growing in one with a divided uterus?
The percentage is low because most of the time it is infertility. Most of the time it is infertility. So we have to remove that septum so that we have enough space for the baby to grow. So that abnormality can actually extend down to even your cervix.
Oh.
You either find you have two cervixes instead of one.
One cervix.
Or instead of one cervix. Or even two vaginas instead of one.
Okay, the more it divides,
yes,
the more you get two things.
Yes, because all these things come during when you're in your mother's womb, they come from two ducts. So any disturbance of those ducts will either give you an abnormality in your uterus or your cervix.
Okay.
And it can also extend down.
Okay.
Yes. So the scan and the hysterosalpingogram are able to give us an idea
of what's happening. Okay.
Yes. And then the other factor we looked at for women is what I call where you find the mucus of the woman is killing the sperms. So this one we can do what we call a post-coital test. And we are able to tell if there is compatibility between the two. Yes.
Actually, I was even going to ask that question. What happens to couples that are incompatible?
When we actually discover that it is the cervical factor, it is the woman's mucus that is actually killing the sperms, then the only way we can get this couple to conceive is if we bypass the what?
The cervix.
We make the sperms bypass the cervix. How do we do that? Is what we call intrauterine insemination. So what happens, the man will give us their sperms, we wash them and concentrate them, but instead of the couple having coitus, we get these sperms and pass a small catheter through the cervix, and then we push these sperms into the uterine cavity. So once they are there, there's no way the cervical mucus is going to kill them, and that's how we get them pregnant. It's called intrauterine insemination.
Okay.
Yes.
We have of course talked about family planning, and I am wondering, what does family planning or contraceptives, what role do they play in infertility?
Well, the contraceptives actually play two roles for us. One is a good one. One, the population may look at it as a bad one.
As a bad one, yes.
So the fact is, some of these family planning options, especially the hormones, when you stop using them, you may not return to fertility as soon as stopping them. You may stop taking them like a month ago, and then you may conceive a few months after that. Unlike the non-hormonal, for example, the IUD. If you remove it today, you may conceive tomorrow,
Okay.
which may not happen with the hormonal methods. Yes. So that is a little bit of the down part of it.
Okay.
But we as fertility specialists, we use those same fertility pills
To treat
the women with infertility, especially even those we are going to do IVF for.
Oh.
We normally give them prior to starting treatment. Because what the pills do is they take control of your cycle.
Okay.
Because with IVF, we normally want to take over the woman's cycle.
So that you have a regular balanced cycle.
We determine when the period comes, we determine when she ovulates. So the pills help us in that.
Oh.
Yes.
Doctor, what treatment plans are there in Uganda?
Okay, so usually treatment aims at reversing the cause, what is causing infertility. So, like I was saying, you basically treat the cause. If we start from the ovary, if this woman is not ovulating, we have medication that helps a woman to ovulate.
Okay.
It's called ovulation induction. So you give this woman medicine, you monitor her egg growth from 0 millimeters up to 20 millimeters when it is ready for ovulation.
Okay. Our time has moved quite fast. We have not looked at the treatment plan, but I guess we shall look at that next week because of our time. You can give us our closing remarks, Doctor, on what we have looked at, and advise, and maybe perhaps even throw in your phone number. These people can call in and, you know, you can be of assistance to them.
Well, what I would say is fertility is real. Infertility is real in Uganda. Couples are suffering, and it comes with a lot of social, psychological stress and financial stress. But what I can assure the infertile couples is there are options. We are no longer limited. Even at 50,
you can have a child.
You can have a child. So just seek treatment in case you're having issues. Seek treatment from a fertility specialist.
Okay.
And they will get you through this journey.
Okay.
It's usually a long journey and needs patience. Don't rush the clinician. So this month we haven't conceived this month. It takes time. But eventually you get there. Yes.
So one quick question before I close out. Is it possible for someone's ovaries to be put in a bank, in an ovary bank here in Uganda, so that when they want to conceive later, they can pick it up, that particular one, without using a donor?
So for the career women who want to conceive in their 40s, that is the best for them. Because we do that. We do egg preservation.
Okay.
We even do sperm preservation.
Okay.
These gametes can be kept for years and years. And whenever you're ready, you just come.
Okay. Okay, your phone number for the guests, for the viewers.
Okay, so it's 078 57 43 055.
Okay.
078 57 43 055.
Okay. That is all we had for today on the show. Next week we'll continue with infertility, and perhaps the doctor will even explain to us how we can have those eggs stored for years. Then when we are done with our careers, we can look at conceiving. I'm Kasule Fenalin. This is the diagnosis, and we love you. Stay watching Rest TV.